Hello, everyone. We're going to cover arrhythmia management. We're going to talk about Brady dysrhythmias and tachyarrhythmias. And in some ways, the protocol is much more simpler, especially when we're talking about treating sick, crashing, unstable patients. But when we're talking about the stable patient and you have a plethora of medications that you have to filter through to decide which one you want to give this patient, it can be a little more convoluted. So we're going to take our time with this training and make sure that you understand the treatments that are available to you. Now, the American Heart Association has this different grading criteria. This is in a way based on the level of evidence for treating, let's say, a particular arrhythmia, and they classify it based on strong, moderate, or weak recommendations. So it's important not only for developing protocols, but also deciding what intervention do I want to try first. Because if we try one intervention and it doesn't work, then we may try another. Depending on the benefit versus risk ratio. Now, essentially, if there's class 3 recommendations where the benefit is the same as the risk or the risk is greater than the benefit, we're just not going to do, because if there's equiphasic or equal risk and benefit, then we generally won't do that unless the patient's going to die and we want to try it because they're going to die if we do nothing. A lot of debate is had between when do we shock versus when do we give medications. And we have to differentiate between, is this patient symptomatic versus are they unstable? Now, symptomatic is when we're talking about is the patient having symptoms. Let's say that they're having a tachycardia, they're in VTach, maybe they're having palpitations, they're a little lightheaded, they're slightly short of breath, but they're stable physiologically. Their vital signs are stable, they're not actively crashing on you. There is time to decide on the most appropriate intervention or no intervention, which is a decision that you'll have to make. And deciding not to do something is, in a way, an intervention. It's the wait and see approach. Unstable is when the patient has symptoms of impaired organ function. All right, so this could be a patient with pulmonary edema and cardiogenic shock. It could be a patient with chest pain. And the treatment for this is obviously electricity. This is either cardioversion, defibrillation, or transcutaneous pacing. Now let's go through each arrhythmia and let's look at the grading criteria. When it comes to bradycardia, I really like the recommendation from the American Heart Association on this. Their class 1 recommendation is to treat the reversible causes of the bradycardia. And we'll get into why I like this in the next slide. Now, their class 2A recommendation is that atropine is reasonable to increase the heart rate. This is something that you've learned in your paramedic program, right? You're going to administer atropine while you're preparing the pacing pads. And if atropine doesn't work, then you're going to transcutaneously pace this patient. Now, the AHA has lowered the recommendation of transcutaneous pacing. If you administer atropine and it doesn't work, then they say that you can try epinephrine or another rate increasing medication like dopamine, which we don't carry, so I took that out. but you can try epinephrine or transcutaneous pacing. But there might be times where you don't have IV or IO access immediately available, and you need to do something now, because if you don't do something, this patient's going to die. That's, in my opinion, where transcutaneous pacing really shines. Is we arrive on scene, the patient is severely bradycardic, they're unstable. I don't have time to get access, so I want to put the pads and pace them immediately. And sometimes we'll walk and chew gum at the same time. We'll try to get access while we're placing the pads. But in this situation, push-dose epinephrine is a great option if the patient's unstable and we really want to increase the rate. You could consider norepi, but epinephrine is really going to increase that rate more so than norepinephrine. So here is my easy approach, my KISS method to treating bradycardia. What reversible causes are there? I think don't let the patient die, DIE. Is the bradycardia caused by drugs, ischemia, or electrolytes? So drugs, we're going to go into our tox metabolic considerations or our tox considerations, and there is a whole toxicology protocol that will outline how to treat beta blocker overdoses, how to treat calcium channel blocker overdoses, but we're not going to cover that for this lecture. But when I'm thinking of a beta blocker overdose, I'm thinking especially of giving glucagon. If I'm thinking of a calcium channel blocker overdose, I'm thinking, I want to give calcium for a calcium channel blocker overdose. Kind of makes sense. And then bicarb may be indicated in certain drug overdoses, such as TCA overdoses, which we generally expect to see tachycardia, but it can progress to bradycardia. We all know that hypoxia can cause the patient to become bradycardic, so if that is a cause, we're going to fix that. And then, of course, hyperkalemia. Hyperkalemia is the syphilis of electrocardiographic findings. It can cause tachycardia, it can cause bradycardia, it can cause wide complex tachycardia or bradycardia. The thing about hyperkalemia is that if the patient's hyperkalemic and they're bradycardic, and we try all these other things like pacing, epinephrine, it's unlikely to work until you fix the hyperkalemia. And to do that, we administer calcium, bicarb, and albuterol, and we have a protocol for that now, which is fantastic. Now, if your patient's not actively decompensating, sure, I'm going to try atropine, then epinephrine. And if we're trying to debate, does this patient have sinus bradycardia versus a high-degree AV block, second-degree AV block, so on and so forth, to me, it's mostly an academic reason that we would do that as opposed to a clinical reason for the pre-hospital providers. In the hospital, for the electrophysiologist, there's probably very meaningful clinical reasons that might drive their treatment to differentiate between them. For us, not so much. If I have sinus bradycardia, sure, I'm going to think about a vagal cause of the bradycardia, but in general, when I'm trying to differentiate between second degree type 1, second degree type 2, third degree AV block, those conversations and considerations are probably more important to be had when you get back to the station as opposed to treating the patient in front of you. Because if I've got a severely bradycardic, unstable patient, I'm not interested in determining the type of AV block if that patient needs treatment ASAP. If I have a patient presenting severely unstable or that's actively decompensating right in front of me, when I am going to begin transcutaneously pacing that patient, I'm not messing around. I'm turning it up to 11. Now that's just a saying. Of course, we're going to turn it up to whatever the max milliamp is on the Zoll, which I think is 140. It goes up to 140 for a reason. But regardless, I'm going to turn the milliamps to their max. I'm going to turn it up as high as it goes because this patient could die at any time. And if I'm pacing this patient and I have time to start off at 70 milliamps, do I have capture? Do I not? No. All right, let's go up to 80. Do I have capture? No. Okay, let's go up to 90. If I have time for that, then generally I would have time for medications. Not always the case. This is our bradycardia algorithm. You'll see that you have multiple options available to you. And I said earlier that in some ways we have simplified the protocols, but in other ways you have to think more. Now, you have to think more when you have time to do so, all right? Because you'll see on the transcutaneous pacing section right here, you'll see that if the patient is actively decompensating, then transcutaneous pacing. Otherwise, if they're not, then you can try these other things when you have time to do so. And if the bradycardia is potentially caused by hyperkalemia, then see hyperkalemia protocol. In another way in which we've tried to make the protocol more simpler for the patient that is, needing immediate intervention, another way that we try to make this easier for you is to provide one across-the-board procedural sedation protocol. Now, we didn't call it procedural sedation. We called it procedural anxiolysis and analgesia, just because procedural sedation is a dirty word that's only physicians are supposed to do. All right, but we called it anxiolysis and analgesia, semantics. But you'll see that this is true across the board. There's indications, there's contraindications to doing this, but you decide when the patient is undergoing, you mostly decide when a patient is undergoing a procedure that is going to cause pain, discomfort, and increase their anxiety. Generally, you're going to do this if you've got a patient that you need to reduce a fracture with. Now, it is not generally in your scope of practice to reduce a fracture unless you're properly credentialed or the patient has poor pulse, motor, sensory function, and you need to realign it for that reason. In that situation, it is true. The same holds true for dislocated joint reduction or chemically facilitated extrication, which is kind of interesting, or if you have to pace this patient, you've got to cardio or pace them. In our old protocols, it was simply, for this procedure, give this. For this different procedure, give this. Nope. Now it's just, here's the medication or medications, and here's the dose. And if you're doing a painful procedure, you can give these medications for that. And it's pretty straightforward for adults. It's straightforward. For peds, it's weight-based, and you would use hand heavy for that. But for Versed, it's 2.5 milligrams, Q10 minutes to a max of 10. For ketamine, it's 10 milligrams IV or 20 IM, Q5 minutes as needed. And you'll see that there's no max dose there for adults. But something that I should highlight real quick is how to prepare and how to monitor this patient while you're doing this. If you keep repeating these medications, especially ketamine, you're going to need to tether this patient to your stretcher by continuously monitoring end-tidal CO2 waveform, ECG and SpO2. And one person's going to need to continuously monitor this patient for respiratory depression. All right. And your goal is to escalate these to achieve the minimum amount of sedation as is necessary to complete this procedure. All right, so the minimum amount of sedation as is necessary. And this is your hyperkalemia protocol. You have a specific training on hyperkalemia, so I'm not going to go into this any further, but just be aware that hyperkalemia can cause bradycardia. When it comes to transcutaneous pacing, you will see that now you can, per protocol, increase the milliamps to the maximum setting. For critically ill patients, hypotension, peri-arrest, unconscious, start pacing attempts at maximum current output because you want to immediately achieve capture at whatever milliamp is required. And then once you get capture, then you can back down. And as you go down, as you decrease your milliamps, you will see intermittent capture where you have it and then you lose it, then you have it, then you lose it. So that's when you increase it 10 to 20 above that threshold. And of course, you have a training all on transcutaneous pacing and the problem. And in that training, I talk about the problem of false capture, which we have seen at our department, where you get electrical artifact because pacing causes artifact, and the monitor can't completely scrub out all of the artifact. And unfortunately, they scrub out a little bit, but what remains can sometimes mimic electrical activity from the heart. So it looks like capture when in fact it's not. So you have to beware of this. And I won't go any further on that because we have a whole training. And if you don't understand that, go back and watch the transcutaneous pacing training. Where do we place the pads? We've discussed this in a CQI meeting, but it bears repeating. Zoe does recommend anterior, posterior for pacing and cardioversion. Now the anterior placement they say is not recommended for non-invasive pacing. So, okay, if we've got logistically, it's easier to place anterolateral when you first start CPR on a patient because that's what's exposed. And you have to stop CPR to roll the patient to place it anterior, posterior. All right. So let's say you start off anterolateral, you get a pulse back, but they're quickly becoming bradycardic, and you don't want to delay pacing to move the pads because that patient could rearrest before you get the time to do so. In that situation, it might be okay to start off pacing anterolateral and then switch them from anterior posterior, which you wouldn't use the same set of pads anyway, so you're not going to pull those off and then pace yourself. That would be bad. Don't do that. I would take a second set of pads, place them, and then disconnect, reconnect. Now, when you disconnect, you're going to lose capture because the pads are disconnected. So you want to kind of try to be smooth about doing that and quick. Now, I said in some ways the protocol is more simpler. In other ways, it's more complicated. When choosing which medication to give the patient for the tachycardia, it can be more complicated. But remember, the protocol is not training. The protocol is not intended to be training. This is the training for how to use that protocol. So listen very carefully. All right. I've tried to simplify this as much as possible to make it easy to understand. And in some ways, I still don't fully understand. But when I first became a paramedic, this was the bane of my existence. I was afraid of treating tachycardias because I wasn't confident. I was so unsure of myself. And in some cases, I probably did not treat the patient because I wasn't sure how to do so. So I'm going to try to clarify this for anyone else who was like me. Um, and if you're not like me and you're confident in treating arrhythmias, then I'm happy for you. But that wasn't me as a new paramedic. Now, calcium channel blockers generally work on atrial arrhythmias. Cardizem or diltiazem is a calcium channel blocker. When we're talking about treating the ventricles, generally sodium channel blockers are the best. So we give lidocaine. Lidocaine is a sodium channel blocker. All right. So for atrial tachyarrhythmias, including SVT, or it's the better term for that is AV nodal reentrant tachycardia, AVNRT, you can give calcium. Calcium works on both. Adenosine generally has one purpose in the pre-hospital environment, and that is for AVNRT or SVT, because that slows conduction through the AV node. And that's why I've placed adenosine kind of over the AV node, because that's where adenosine really shines. All right. So if we have AFib RVR or a flutter, we're going to give cardizem. If we have confirmed unequivocal ventricular tachycardia, we can give lidocaine. Now, what about amiodarone? Where does amiodarone fall in? Well, amiodarone is kind of a class everything antiarrhythmic. You can give it for AFib RVR, but we generally don't. That's why I put it slightly on the side of the effects on ventricles. Now, when choosing between amiodarone or lidocaine, a lot of people can get pretty confused, myself included. But amiodarone really shines because of the different classes that it is in the class 1, class 2, class 3, and don't ask me to tell you which is which, but amiodarone is a class everything, and if I give it for ventricular tachycardia and it just happens that that patient had a left or right bundle branch block and then went into AVNRT or SVT, it's going to be wide, fast, and regular, which, okay, I'm treating as ventricular tachycardia like I'm supposed to, but you know what? If it might work if it's not VTAC, even if it's SVT with aberrancy. Now, let's go through, and this is a busy slide. All right, so I'm going to try to break it down as simple as possible. Let me move myself real quick. I like breaking it down this way because it shows what the AHA recommends, how they classify things, right? Class 1, Class 2, Class 3, and it gives us a sequence in which we could go by to treat these patients. Now, let's start off with stable wide complex tachycardia. They say that the benefit is greater than or at least equal to the risk. And this is pretty well established that, this is what everybody does for wide complex tachycardia. They say that IV adenosine may be considered for treatment and aiding rhythm diagnosis when the cause of regular monomorphic rhythm cannot be determined. All right, so we have said that, okay, for ventricular tachycardia, wide, fast, regular, just assume that it's VTAC. VTAC until proven otherwise. Well, why are we giving adenosine? Well, the answer is you don't have to. You can choose to give adenosine if you're unsure. All right. Now, how can you be sure if it's VTAC or not? Because you're always taught, I have said that wide, fast, and regular is VTAC until proven otherwise, right? So that means you should always go with amiodarone. That's not always the case. All right. If I have a young patient that is in VTAC, I'm thinking that adenosine might work on this patient because there are some forms of ventricular tachycardia where adenosine does in fact work, and that is like right ventricular outflow tachycardia. And I recently talked to a cardiologist, and he was of the same opinion. In most cases of wide, fast, regular tachycardia, he gives amiodarone, especially if they're older, they have a pre-existing heart condition. If that patient is in a wide, is in a stable wide complex tachycardia, then it is most likely that they are in ventricular tachycardia. All right, so for older patients, my go-to is going to be amiodarone. Now, amiodarone can cause the blood pressure to drop, especially if it's already marginal. But in most cases, your go-to is going to be 150 amio over 10 minutes. If I'm unsure if it's kind of narrower than typical VTAC, and no, I don't have a set millisecond between to differentiate between narrower and wide. I don't have that. All right, but let's say we call it wide if it's greater than 120 milliseconds or 0.12 seconds. We'll just say, for the sake of discussion, that they're right on that. They're right at 120 milliseconds. Okay, let's try adenosine. They're a little younger. All right, let's give adenosine a go. Okay, but if it converts with adenosine, that doesn't mean that it wasn't VTAC, because again, there are some forms of VTAC that will convert with adenosine, and generally those patients are younger. They're more stable. All right. I think I've gone through that enough. Polymorphic VTAC with a long QT interval, or polymorphic VTAC without a long QT interval. What's the difference between that? Is it still polymorphic VTAC? Well, technically, all right. But if this patient is in what looks like torsades and they have a long QT interval, then that is torsades. Okay? If they are in polymorphic VTAC without a long QT interval, then that's not torsades. Is this clinically relevant to differentiate? Because a lot of times if we arrive on scene and they're in what appears to be polymorphic VTAC, we don't have the benefit of knowing if they have a long QT interval, because we didn't get the 12 lead before they went into the polymorphic VTAC. So how would we treat that person? Well, generally you're going to treat them with defibrillation, because most of the time you can't sync that, or if you sync it, it's going to sync where it wants to sync, because it's going to sync on either the Q wave or the T wave. We're not going to know, so we're just generally going to defibrillate torsades. All right. But if you know, let's say you've got a patient, you get called for some chest pain, you run a 12 lead, the QT interval is not long. It's different between males and females what they consider a prolonged QT interval or not. But over 500 milliseconds of a QTC is a long QT interval, regardless of the gender or the age. So let's say it's around 500 milliseconds and the patient's throwing PVCs, and then they go into polymorphic VTAC. Well, we call that torsades, and the treatment is magnesium. All right, that's a class 2B recommendation. But the benefit is greater than or equal to the risk, so we're going to give magnesium. Now, if we get there, they're having some chest pain, we get a 12 lead, and the QT interval is not long, let's say it's 450 milliseconds or less, and then they're having PVCs and they go into polymorphic VTAC, we can give lidocaine or amiodarone to that. But why would we give it to the person without a long QT interval, but not the patient with a long QT interval? The reason is that these medications can prolong the QT interval further, while magnesium can shorten it. All right. Now, what about regular narrow complex tachycardia? This is our bread and butter run. We love these calls because we know exactly what to do. We generally don't like the other calls because it's confusing. But with regular narrow complex tachycardia, so the QRS is less than 120 milliseconds, and it's fast and regular, vagal maneuvers. All right, so we're going to do modified Valsalva maneuver. We're going to give adenosine 6 and 12. What if that doesn't work? Are we just up the creek without a paddle? Not necessarily, because now you can give cardizem. You can give IV diltiazem. All right, which is kind of cool. AFib, aflutter. This is straightforward. You all have been doing this. Not much has changed in your protocol. Just remember that we only give this if it's kind of abrupt, sudden onset, and it's not compensatory, because AFib, RVR, is kind of like sinus tachycardia in that way, in the way that it can be compensatory. So the patient could be hypovolemic, they could be septic, and they could have AFib, RVR. Well, that's just like sinus tach. We're going to treat the underlying cause. And generally, we don't give IV amiodarone for AFib, RVR in the pre-hospital world because, it's going to take time to determine that this patient is not responsive to cardizem for rate control. And amiodarone can convert AFib, RVR to a sinus rhythm, which could be bad if they have developed some clots that could dislodge from the atrium. Okay. Now, what about lidocaine? A lot of people will ask me, can we give lidocaine for VTAC, or do we always have to give amiodarone? The answer is yes and no, to quote Chris Wilhite, Assistant Chief Wilhite. This is directly from the AHA, and I'll show you what our protocol says. They say, lidocaine is not included as a treatment option for undifferentiated wide complex tachycardia because it is a relatively narrow spectrum drug that is ineffective for SVT. Amiodarone, however, in addition to these other medications, they're broader spectrum. So basically, the AHA has dumbed it down for us, and they're like, if you don't know if it's SVT with aberrant conduction, meaning, again, that the patient has an underlying bundle branch block and they go into SVT, if you're not sure if it's SVT or VTAC, then just throw amiodarone at them. But again, I've kind of showed you how to be more certain that it is VTAC as opposed to SVT with aberrancy. And that is basically obtaining a good history. Older patients with a cardiac history, wide, fast, regular, then it's most likely ventricular tachycardia. Would I give lidocaine to this patient? Sure, especially if their blood pressure is soft, because the other things can cause hypotension. Amiodarone can cause hypotension. And if I've got a patient with a marginal blood pressure, I'm like, okay, I don't really want to cardiovert this patient because they're relatively stable, but I also don't want to give amiodarone because it could lower the blood pressure. I'm stuck kind of in between a rock and a hard place. hey, let's just try lidocaine. But again, if the blood pressure is marginal, maybe I want to at least pre-apply the pads, get them ready, which I should do anyway, right? Right. Um, so this is a busy chart showing all of the things that these different drugs can do. And it's worth covering them individually again, just to drive some of these points home. Adenosine relatively straightforward. It's important to point out with adenosine, though, that it can cause bronchospasm, so we want to not give it to patients that have asthma, possibly also COPD, or we want to be extremely cautious for that. Adenosine also causes this sense of impending doom, where the patient feels like they're going to die. It's very uncomfortable. You may actually have a patient that has a history of SVT and they might refuse adenosine, in which case you could give cardizem. All right. Now with cardizem, adenosine, and amiodarone, we avoid them if the patient has AFib with WPW. And if you still don't know what that looks like after me talking about it 1,000 times, you've got to know what AFib with WPW looks like so that you can avoid these drugs and not harm the patient. Amiodarone is straightforward. It's a class everything blocker. Magnesium, again, we give it with polymorphic VT with QT prolongation.